Okay, I think I'm live. All right, so I want to go through this thing I've been working on, and I'm pretty excited about it, and I'm going to probably keep doing this for a while. So what I want to talk about is what is atrial fibrillation? It's the most common arrhythmia. It's one of the most common causes of stroke. So it seems a far cry from what this group is supposed to be about, but it really isn't, much to my amazement. It's an amazing history. So I want to sort of kind of go through what atrial fibrillation is. It's complicated. As a neurologist reading cardiology literature, I realized how complicated it is. Then I want to talk about the fact that atrial fibrillation doesn't start in the heart. It actually starts outside the heart. I want to kind of go through that. And that in fact, the triggers for what triggers a atrial fibrillation is being set off by traction, by stretch, and in particular by traction from the diaphragm. That last bit, that the traction is coming from the diaphragm, that would be, I'd have to say, my own solution hypothesis. Everything else that I'm covering is solidly in the literature. And then in addition to traction from the diaphragm, the vagus nerve, the parasympathetic acetylcholine system seems to play a role, more so than the sympathetic nervous system. And then finally go with what do you do about it, and what I've been doing in terms of identifying tension in my own diaphragm and how I go about getting rid of that tension. So here we go. So I'm actually going to try to use the slides, and I think I'll just count on you, Very, to yell at me if this isn't coming through. Okay, so let's just start with what atrial fibrillation is, because it's complicated. The word fibrillation, you just bet somebody in the 1800s in Europe came up with that term, fibrillate. But so a normal heart is on the left there, and normally speaking, when the sinus node, I'm zeroing in on with these little square arrows, the way it's supposed to work is the myocyte, the cardiomyocyte in that location, maybe a small group, but it might even be just one myocyte. It's activated by a combination of the sympathetic nerve and the vagus nerve, the two of them. The sympathetic nerve is secreting adrenaline, noradrenaline, and the vagus component is secreting acetylcholine, and the balance of those two determines the heart rate. That's at the sinus node. Once that sinus node is fired, it propagates. The pathways go out in all directions. So some of the paths go down into the right ventricle. So it starts in the sinus, the sinoatrial node in the right atrium. The signal then goes down into the right ventricle, across the left ventricle, and across to the left atrium. Essentially, all atrial fibrillation starts in the left atrium. So over here is the left atrium. And so what this drawing is trying to show is, instead of having a nice, straightforward propagation of a single impulse outwards in all directions to cause the entire heart to beat in a synchronous pattern, causing blood to be pulsed out into the lungs from the right atrium and into the rest of the body and brain from the left atrium. Instead of that happening, what's called re-entry. They call it wavelet re-entry. Multiple wavelet re-entry is the term they've come up with. The literature on it is complicated and goes way back to 1850, but it's pretty much been agreed upon since 1977. And so what's going on in an atrial fibrillating heart is, instead of having a nice clean sweep of activation, it's in all directions. It used to be called chaotic, though it turns out it's not really chaotic. It's just sweeping round and round. And as one group of cells get activated, another group goes into a quiescent stage, and they loop around and around. And that looping around and around in all directions is what atrial fibrillation is. And when that's happening, it's not beating, so therefore no blood is going anywhere. It's not doing any good. So instead, at the bottom, you see a normal heart rate, a steady QRS complex, a P wave, a QRS, and a T wave, very steady. Instead, you have what's called irregularly irregular. So when you do an EKG, even a dumb neurologist can look at that and say, yeah, that's irregularly irregular. That is atrial fibrillation. Well, why is it that rate? If up here in the atrium, these circles are spinning around, kind of feeding each other like a snake chasing its tail, why do you get this? And the answer is because the ventricles cannot keep up with this fibrillating, cycling, vicious cycle of activity, and so only some of those some activity gets through to cause a heart rate. So if you actually look down here, you see on the left side there's what's a P wave right before every QRS wave, nice and neat. Whereas over here you don't have nice neat Q waves. In front of each QRS complex, you see all this wiggling because it's not in a propagated manner. So that's what atrial fibrillation is. Why is that bad? It's bad because you feel lightheaded, the thing is not pumping well, you don't feel good. Though interestingly, apparently, most people who have atrial fibrillation don't know they have it. You know, talk about lack of awareness of one's body, they don't know it. I mean, that's very dangerous because what happens is, let's see if I have a better picture of that. I'm going to use this one down here, even though it's a jump. So this is sort of a side view, normal heart and not normal heart. So here's the left atrium that we've been talking about. So I'm going to go back. This here is the left atrium. And now in this other view, that's a schematic. So down here, this is the left atrium. And when this left atrium, this pink orangey structure, is not firing properly, it's fibrillating, it's wiggling. This thing here called the left atrial appendage, this thing here is like a sac that's just quivering. And so what happens is blood coagulates in it. It creates a clot, and that clot can break off, go out into wherever it's going to go, but in particular, if it goes into the heart, into the brain, if it goes up the carotid arteries and lodges in one of the arteries in the brain, you're going to have a stroke. So that's the problem. That's why I'm titling that heart attack. So it's not really a fair definition. I mean, if anything, that would be a brain attack if that happened. But still, atrial fibrillation is dangerous. If you don't do something about it, the treatment for atrial fibrillation is blood thinners, because they don't really have a way to stop that heart from fibrillating. And I think maybe I have a way to treat it, and that's what this little talks about. So let's kind of zero in on what these pulses are. So this is an action potential. Action potentials are really the same whether it's a neuron that's sending a very fast one. Here, let me show you the fast one. So here is, in red is a neuron action potential. Where's my marker? This red one is a neuron action potential. So what you're seeing is it has an amplitude. It goes up and has an amplitude, but it's very fast. So this whole action potential only lasts a number of milliseconds. Right beside it now is a different cell. So here we're showing that neurons have action potentials, but also smooth muscle has action potentials, cardiac muscle, skeletal muscle, muscle spindles. So these are the different kinds of tissues that have action potentials. Other kinds of tissues don't. Liver doesn't have it, pancreas doesn't have it. Most cells in the body do not work by using action potentials, which are sudden depolarizations causing the rise in the action potential, and then it repolarizes. And then there's what's called a refractory period. During this refractory period, another stimulus cannot stimulate another action potential. whether it's a neuron or a muscle cell or a cardiac muscle cell. The heart is muscles. So during this refractory period, another stimulus can't fire it. And so that's an issue with atrial fibrillation. When you see this cycling around, part of what sets the speed of it is how long those refractory periods last. If the refractory period very long, then it can't fire again. So paying attention to that is important. So this is your standard action potential, whether it's coming from a neuron or a cardiac muscle fiber. So in the next slide, for instance, we see a couple of different patterns. This is smooth muscle. So smooth muscle also has an action potential, but for instance, this bottom one here, this is the smooth muscle of a uterus. So you see, doesn't go quite as high. So the typical neuron goes as high as 30 microvolts, whereas a uterus smooth muscle that starts at a lower level of microvolts and only goes up gets up to the baseline. Over here on this side is intestines. So what's intestine? It's smooth muscle. It's sort of like a snake that squeezes along its way, right? Not much going on down there. We don't pay attention to it. We pay attention to what comes out of it, perhaps, or if we get nauseated, but it just does its thing very slowly. Look at the time frame. The time frame is seconds. So each one is 5 or 6 seconds long. 1 1,000, 2 1,000, 3 1,000, as opposed to an action potential from a neuron, which is a very few number of milliseconds, much, much faster. So that's smooth muscle. Okay, so that's how that system works. And so what's going on is, so this is kind of an overview of the heart. I hope this doesn't freak out Vera. She doesn't like anything that looks too gory. But this is Frank Netter. These are the most famous anatomical medical drawings that there are. Every medical student uses these. And so just to kind of get us the overview, this is the pericardial sac. See how it's attached to the diaphragm. And then you can see the blood vessel, the veins and on either side going in. So that's sort of the overview of what we're looking at. The lung has been pulled back so we can see the heart. So now let's zero in. So this is now inside the heart. This is from Gray's Anatomy. These are also very famous old diagrams. And by the way, I did get permission to use. And so once again, we see the pericardial sac. And then we see that here's a good view of the fact that that sac is attached to the diaphragm, right? And that these here are the pulmonary veins. So what we know, the literature makes it clear now, is atrial fibrillation does not start in the atrium. It starts in the pulmonary veins that enter the heart. And here's the entry. So they don't show the pulmonary vein in this picture. What they show is what's called the ostia. These are the holes, the orifices where the pulmonary veins, there's 4 of them, 2 in the left atrium, 2 in the right atrium. This is where the blood, in this case, from the heart comes in, and here's where the blood, from the lung. So the lung returns the blood into the left atrium. The body returns the blood into the right atrium. This is where it enters. All of atrial fibrillation, basically all, starts in the pulmonary veins, not in the heart. Okay, and then what we know is that the pulmonary veins fire when they're stretched. So here's this next drawing. So this is a really key drawing. On the y-axis is the frequency of firing. What the heck is a pulmonary vein doing firing? Isn't it supposed to be the heart? Well, that's the point. The smooth muscle of the pulmonary veins has its own low-grade action potential, but there's also then a sleeve where these blood vessels first leave the heart and go out into the vein. They leave, let's see, maybe this picture is going to show it better. Well, so it's the same thing. Here are the pulmonary veins, and this what's called the sleeve, this little section of the pulmonary vein that's left the left atrium. So here's the left atrium, which is cardiac muscle cells. The pulmonary vein is in general, these blue veins are in general smooth muscle, but there's a sleeve of cardiac muscle which surrounds the pulmonary vein where it first begins, and those discharge. They send action potentials into the left ventricle, and they specifically do it when they're stretched. So where I kind of zero in on this is that what's causing the stretching? There's general agreement that the atrium is normal. This atrial fibrillation is happening in a normal muscle, which is in a normal heart muscle, which is going into this vicious cycle, being triggered by discharges from the pulmonary veins that are entering in the left ventricle. And we know that that's happening from stretch. Where is that stretch coming from? And sort of the case I'm making is that that stretch is coming from the diaphragm, that this diaphragm down here is pulling on the pericardial sac, pulling on the pulmonary arteries where they enter the heart. That's what's causing the discharge, so that with more tension, more stretch on those pulmonary veins, we get more discharges. So this is the discharges on the y-axis. This is the pulling on, the tension in milligrams of pull on the pulmonary veins. The more it's lower, and as you increase the tension, the pulling on it gets greater. So this is the part that I would have to say is theory at this point, but everything, all the different papers I would say support this idea. So therefore, it now becomes, what do you do about it? And so this is when we get back to where I was before. Why have I been so interested in the diaphragm? I've been interested in the diaphragm initially because it's the site of where we feel chest ache. So when we have a chest ache, when we are in withdrawal, or we are longing or pining or craving food or a loved one, the sensation of chest ache is we call it cardiac, but in fact the sensation is coming from the diaphragm. So this is what the diaphragm looks like, and this is my favorite picture because Very hates it. This is literally what a diaphragm looks like, and I think it's worth seeing it to point out that it is a muscle. It's a muscle like our trapezius muscle or our bicep muscles or any other muscle, and it's got different parts to it. So this is the back, and this is the back. This is where the esophagus surrounds this is where the crural part of the muscle, it's called the crural diaphragm, this section here surrounds the esophagus. It's mostly studied by gastroenterologists because this is the sphincter of the esophagus. This is why food does not come back up. For hundreds of years, it was thought that the esophagus itself had its own sphincter, and it turns out that's not true. It's this structure here, the crural diaphragm, that constricts to prevent food coming up when we cough or strain or something else. And then the rest of the diaphragm is what we use to ventilate. We mostly think of the diaphragm as a ventilatory muscle. All along the edge, this is attached to our lowest ribs. Do I have a better picture of the lowest ribs? Well, here are the ribs along the side, looking like we're at the, having ribs at a restaurant. So these are the ribs. This is cut through them. So the very bottom rib goes around the outside, and the diaphragm attaches there. So the diaphragm is attaching to the side there, all the way around the edge. And so when we breathe, this what's called costal part of the diaphragm contracts, and when it contracts, it pulls together, and so it pulls downward. That's why when we breathe deeply, our belly protrudes, because as it's contracting and pressing down, everything below it, the stomach, the liver, the pancreas, the intestines, the gallbladder, they all get pushed down, and so it pushes out our belly, and that's why our bellies stick out when we do that. So this is the structure that is causing tension, when this structure becomes tense, just like your neck muscles become tense or your low back muscles become tense, when this structure becomes tense, and in particular where this part of the muscle becomes tense, tense doesn't mean contracted. You can have your muscles in your shoulders be tense without contracting them. We tend to contract them a little when we are tense, but you can pay attention and tell yourself to lower your trapezius muscles back down again, even though you're still feeling tense. But in general, tension can be differentiated for very specific reasons because it's controlled by the muscle spindles, which is a part of the muscle. You can control that and not have your shoulders go up. So basically, I've been very interested in paying attention to tension in the diaphragm, the sensation of ache in the chest, because it's a signal that you're wanting something and you're not getting it. That's interesting. But now I have a whole new importance to it because it becomes clear that at least for someone who's susceptible of atrial fibrillation, as I am, that there's a risk to it. You cannot ignore chest tension, because not only it means you're ignoring whatever it is you're wanting that you're not getting, but it also means that that part of the heart, where's my favorite picture of that? That this structure here, and in particular this structure here, is not beating properly, it's quivering, and therefore clots can be forming. And if a clot forms there, eventually it's likely to break off and go up into the carotids and cause a stroke. So it's more than just an issue of emotions, it's an issue of cardiac health. So in summary then, this is what I do now. I pay neurotic attention to my chest sensations. If I have chest tension, I immediately do two things. I first of all try to figure out where it's coming from. I think I mentioned once before, I had it 10 minutes before the final episode of Game of Thrones, but usually it's more of a, let's say, psychosocial wanting. There's something I want, some kind of relationship change or something like that. I quickly do pay attention to it, but I don't just say, okay, I'll make a note to myself to go and call up that person or write them a note. I also immediately do diaphragm stretch. And so I think I want to eventually talking about exactly how to do the diaphragm stretch. I think it's going to be its own talk. In fact, I'm probably going to have to strip half naked and demonstrate with this gorgeous body how to do the actual stretches. But you can pay attention to your diaphragm and you can notice where the sensation, and you can stretch it. Think of it as in the beginning of you do a deep inhalation, so that will generally stretch the entire diaphragm. But sometimes the tension is not in the entire diaphragm. Sometimes it's more localized. So it helps to start by taking some very, very extreme deep breaths to try to get a general stretch. But there's more to it than that. And there's a whole yoga method called, one of them being Uddiyana Bandha, which is, they spent 1,000 years coming up with just the right way to do part of it, not the whole thing. Now, paying attention, in addition to the tension and the sensation of tension, if I get a bubble sensation, and so if you've ever had a skip beat, you'll know what I mean by a bubble sensation. It's quite localized. It feels like the size of a ping pong ball, but it's a definite discrete sensation. If I have that, then I am worried that I may be having a PAC, a premature atrial contraction. So it's also known that premature atrial contractions are also triggered by pulmonary vein stretch. So, and it's also known that if you have a series of PACs, a train of them, you are likely to be about to go into atrial fibrillation. So when I feel a bubble, I immediately do the stretch, and I also have this cool little mobile phone. So let's see how fast I can do this without. So I have this nice app called Cardia. And basically I turn it on, and this little tiny device is basically, you put your fingers on it, you put 2 fingers on it like that, and it will read out your a single line of your EKG. So I can immediately find out, is it regular? Is it a little fast? So often if you're exercising or you're anxious, it'll go faster, but it's still regular. So that's called tachycardia. That's you're supposed to have your heart beat faster when you're running or when something's going on. Or is it skipping? Is there a PAC in my case? And in some people's cases, it could be a PVC, premature ventricular contraction. In my case, it's a premature atrial contraction. If I see a PAC, I'm nervous. I think, wow, I could easily be about to go into atrial fibrillation. So in that situation, if I'm seeing PACs, the next thing I do is I take a small dose of a beta blocker. So, you know, this is going to vary. This is something, if you have atrial fibrillation, you're definitely going to want to have a cardiologist. You already would have a cardiologist to help you. There's different beta blockers. I happen to take one that's really, I like sort of the old one. So there's one called atenolol. It's been around for 50 years. It's like $5 for months and months supply. And so the normal dose for people would be 100 milligrams. I take 12 milligrams at that spot right then, right? And then I immediately go into my full-on stretch diaphragm program. I take my time out. I spend 10 minutes seeing which part of the diaphragm is seeming tense, stretching that part of the diaphragm by various kind of maneuvers of inhalation and stretching. And then I also do HRV biofeedback. So HRV biofeedback is something new. We've talked about that before. It's a whole nother lecture in its own, how you measure heart rate variability. It's been discovered that the vagus nerve controls that system to subtly change the heart rate. And so if the vagus nerve is withdrawing, it's not acting appropriately, then that is going to be an added trigger. So part of this process is the research is also very clear that the autonomic nervous system also plays a role in triggering AF. So I immediately go into that too. If I don't do that, I will go into atrial fibrillation. So this is something I was having, it used to be a couple times a year, but in the last year, it's been more like a couple times a month. And then just in the last 2 months, the cardiologist was fiddling with my medication, and I was having it once a week. So since I started this program, I have had no atrial fibrillation, and I've had PACs, premature atrial contractions, 1 or 2, but I immediately start doing this, and so they stop. I don't have any more of them. So that has been working for me, and that's why I'm telling you about it. If I didn't, the next thing I would do would be to take a different medication called sotalol. It's also a beta blocker. The cardiologists seem to think it's better than the other ones for atrial fibrillation. To me, looking at the underlying chemistry of it, they look pretty similar to me, but they think it works better, so I take that one. So I take 2 beta blockers, right? I take an old-fashioned one, atenolol, if I'm just wondering. But then if I'm in AF, I take the sotalol beta blocker. And then I got to start a blood thinner, right? So so that was really part of my life. I have friends who take blood thinners. The one everyone likes nowadays, Eliquis, is $500 a month. That's a reason itself to come up with some better way to treat the problem. And then I do this diaphragm program of mine hourly. And even then, I'll probably stay in AF for 2 to 6 hours. Before, it was 2 to 4 days. So the last AF I had, maybe 3 or 4 weeks ago, it took, I think, 4 hours to finally end. Still much better, but still, that's what it took. Okay, I'm going to stop there and see if there's any questions. So I see my most recent note, it seems to be from Very. Is that yours? Wouldn't it be nice if everyone at risk for heart attack knew this and how to monitor how their body feels. Just learning the diaphragm stretching could make such a difference in longevity. Yeah, I should charge for it, don't you think? So let's see. Any other questions? I think at this point, I'm going to try clicking the refresh button just in case I'm missing something. All right, we'll stop the video. Barry, I'm seeing, looks like you posted a note from Troy, but I don't see his note. So you must have, he communicated with you in some other way and then you reposted. Is that what's going on there? So here we go again. You're telling me it's on a video chat. I am looking at the Healing Hurt Clinic page. So are you talking about some other page? No, I guess I still haven't figured this out. I see the lecture that has a final slide, summary to prevent my paroxysmal AF. I do. I see that, and I see your last comment, replying to Veritas, but I don't see some other place if you're talking about it. So if I'm right, there's no one having any questions on the Facebook page. All right, I'll wait another minute. Basically, all I see is very your last comment dated 2 minutes, 2 minutes ago. So you're referring to something else, I guess. This is Troy you're talking about. Troy is not on Facebook. Okay, I'm not going to respond to Messenger because that doesn't do anybody any good. So I'll respond to what you wrote on the clinic wall main column. So let's see. You know, the whole, what's called GERD. So there is one of the other most common atrial fibrillation and risk of stroke There's another condition that's also very concerning with this particular part of the diaphragm, gastroesophageal reflux. It can actually be quite serious because if you get damage to the part of the esophagus from reflux, from acid coming up into the bottom of the esophagus, it can damage the bottom of the esophagus and actually can be a source of cancer. And so we now know in recent years that it's not the esophagus that is weak, but it's the crural diaphragm around the bottom of the esophagus that needs to constrict. So there's a reflex that automatically constricts it. But if that's not working correctly, if it's for whatever reason, whether there's an anatomical problem or a physiological problem, then there will be reflux. And that reflux will go up and give essentially what is called heartburn. That system is gastroenterologists are very focused on that. And I am suspecting that more attention to how one can strengthen and increase the normal tone of that part of the diaphragm could very likely be helpful in treating that disorder as well. Now about the breathing, I'm not sure that is specifically related. Unable to breathe. Troy, if you're refluxing gastric contents up into the bottom of your esophagus, it's certainly not going to feel good. But unless it's really going all the way up and you're essentially gagging on vomit, I don't think you should have a problem breathing. So I don't want to make any strong statement about that. So I don't think anyone else is asking any questions on the Facebook page, although I know Viri is using Messenger separately. I'll just try refreshing, and if there aren't any more questions, then I will sign off. I do see another message from you, Viri, where you're saying again the diaphragm. So I guess I must be in the right place. And I think that's probably it then. All right, Viri, I'm going to sign off. I'm going to wait for you to tell me it's okay on the Facebook page, not on Messenger. Hey, Evie. Okay, thanks everybody. See you next time.